Hi, everyone. Welcome to this webinar. I can see that we've got attendees logging in. My name is Dr. Anuji Agarwal. I'll be talking about interpretation of AMH, how it influences fertility management in your day-to-day practices. Feel free to log in your questions as we keep going, and I will answer them in the end. This webinar is meant to be short for about 30 minutes, and I'll try to cover the most day-to-day questions that people have. What is AMH? How can we use it in our clinical practice? Oh, sorry. So I practice around Bendigo. I have finished my master's with reproductive medicine from New South Wales. I don't want to keep talking about myself, but basically I work with Monash IVF and I'm a fertility doctor. So you submit your questions through a Q&A button at the bottom. Please do not hesitate. Ask as many questions as you like, and I'll try and answer them. This is the time to be anonymous and have your queries answered. So first question is, what is ovarian reserve? As we know, women are all born with finite number of eggs. It's anywhere between 2 to 4 million of eggs that women are born with, and subsequently these eggs reduce both in quality and quantity as women get older. Some women deplete their eggs faster than the others, and often there can be some medical reasons like the Turner syndrome for a rapid depletion of eggs, but often we don't find any reasons, and everybody has a varying rate at which women deplete their eggs. But with the advancement of science, at least we can identify some people who will deplete them faster. Unfortunately, we don't have really good tests, but the ones that we do have available to us is AMH and antral follicle count, which is ultrasound based. Antral follicle count is user dependent, so it's quite difficult to have that accuracy based on the ultrasound, the person who does it, and the time of cycle to a degree. And it provides us that information. AMH, on the other hand, is a blood test and is fairly reliable on its report. Again, as I mentioned before, the most important predictor of the quality is age, and it diminishes as the women get older. And these two tests can help us identify who is at risk of having a better IVF outcome to a degree. This AMH and AFC does not predict the couple's ability to conceive spontaneously month to month. Every month when a person conceives, they have the ovary relieves one follicle and then one egg. Therefore, we all need, even with an AMH of 2 or 3, they are able to conceive. But it's helpful information to see what the prediction is going to be for future. I'm going to give an analogy very shortly, which I always use for my patient, let's assume that you're in a big boss house. For example, in a big boss house, you have a pantry, and that has all the eggs that a woman is going to be having for her life. So, for example, you have all the ingredients that you're going to need for the whole life. And there is no refrigerator in the house. Every month, you get given the number of supplies that you need to cook dinner. Similarly, every month, a woman is ovulating. And therefore, you ovulate only once. One follicle grows, ovulation happens, all the other eggs gets degenerated. Similarly, in the big boss house, dinner is cooked. You only can eat so much. All the other supplies gets wasted. But something is happening in that pantry. There is a leak. There's a water leakage. There is something wrong with the pantry. So the ingredients in the pantry is depleting. Things are getting rotten or wasted, for example. This one GP, some smart doctor, has done an AMH and figured out that there is a problem in the pantry. And then a referral got sent to a doctor who then decided, oh no, that something is wrong, so we're going to have a party. Too many, all the dinner got cooked, all the food that was otherwise getting degenerated got cooked and then got frozen. And that is what the effect of AMH is in terms of in that 1 month, what eggs would have otherwise got degenerated, got taken out, and got frozen. I hope I'm making sense. So every month, one follicle is growing, the rest are getting degenerated. When the reserve is low, one follicle is still growing, but at one point it will stop because the AMH is lower and lower, the reserve is lower. The number is not directly proportional to the reserve. So when the AMH is 2 or 3, it doesn't mean they have only 2 or 3 follicles. It's just a reflection of in the graph. Who should test for AMH? That's a very good question. Sorry. It should be tested for the people who want to make informed choices. There's no point in testing an AMH for the person who is not in the position to do anything about it. So essentially, people who want to do something about their fertility, young women who are single who want to freeze their eggs, or women who are at risk of premature menopause. For example, if they have a sister or who has had early menopause, or if their mother has had early menopause, somebody who's had previous surgery on the ovary, lost an ovary, has had chemo, radio, of course. That's pretty obvious. But people who want to delay their pregnancy for any reason because of illnesses or something else, and before and after endometriosis surgery, especially for women who have endometrioma. What is AMH actually measuring? The granulosa cells, they release antral AMH into the bloodstream. Basically, it's an anti-Mullerian hormone, and all the granulosa cells are releasing AMH into the bloodstream, and that is what we are testing for. A low AMH, again, like I said before, it does not predict the chances of conception or a live birth. You can have low AMH, but if you're naturally trying and ovulating, you can get pregnant. So often I say, if I see a 40-year-old woman, assuming that the quality is good, a 40-year-old with a low AMH is a whole different person from a 40-year-old with a high AMH. Because when you have high AMH, I can get lots of eggs, and therefore find a normal embryo by testing and then get them pregnant. Whereas a 40-year-old with a low AMH, when we don't have eggs, we can't get them pregnant. Sorry, these slides are just a bit clunky. I'm not sure what happened there. Okay. So similarly, if like that 40-year-old, for example, if she has an high AMH, it does not mean that we can definitely confirm that the ability to fall pregnant is there because AMH is not a reflection of egg quality. So again, high AMH does not mean that we should exclude the patients from IVF because again, just to give an example, high AMH is seen in women with PCOS because they have high number of follicles. And then again, low AMH means low number of follicles. Then fluctuation of AMH is usually seen throughout the menstrual cycle. It is not seen in the menstrual cycle. So AMH is pretty stable in the menstrual cycle. And then AMH is significantly affected by oral contraceptive pills. Occasionally, we see women who are on the pills and then have AMH tested. It's almost halved in that. So women should be off the oral contraceptive pills minimum for a month, sorry, minimum 4 weeks before having an AMH done. So what is the consideration that women should have before testing AMH? What would that information of low AMH mean to the patient? If they don't have means to act on it, then maybe we shouldn't test the AMH because that would create unnecessary panic. As I said, they are able to fall pregnant. If they're naturally trying to conceive, maybe don't test the AMH. Worry about it in 6 months, or if not pregnant. But if they have the means to do something about it, if they want to act on it, if they're asking for information, then yes. If you see a single person who's talking to you and saying, I do want to know what my fertility is, then yes. Would that AMH change their plans if someone comes to you and says, oh, look, I'm not sure I want to do something, but I do want to find out more. Maybe I want to freeze my eggs. And that is the group of patients we definitely want to test. I just saw someone today who said, oh, maybe I'll think about in 12 and 24 months. But when we look at the AMH, it is quite significantly reduced, and that changed their plans. We can freeze the embryos, but maybe not fall pregnant. So that gave them the 12 to 24 months that they desire, but we could act sooner for better outcome. If they have the resources to egg freeze, then definitely that is something we should be doing, because they will require less number of cycles for what they ultimately want. And are they in a position to start a family? Of course, that would prompt them similar to what I said. Um, we obviously we know that age is so important when it comes to women and their fertility. As women get older, their fertility declines, but it's not like a number. It's not like 35 and decline. It's a gradual progression. Um, and but definitely statistics. So as women go, the equality decreases, the reserve decreases, and also there's an increase in chromosomal abnormalities with increasing age. And so it's really important that we start talking about AMH, and the age, low reserve, age combined with low reserve makes pregnancy really challenging without assistance. Like older women, they're less likely to obtain a chromosomally normal embryo, which is why having good quality eggs along with good number is helpful in the IVF process. And in that group, if we test the embryos, then we beat time. So let's say we got someone who's 38 with a high reserve, then we can get more eggs, test the embryos, and make them pregnant faster if we have a tested normal embryo and put it back in. That same woman who comes in with a low reserve, then we just have to do with the low number of embryos that we have. So essentially, test, transfer, faster route to pregnancy, reduce risk of miscarriage. Again, that same woman, if she was seen at 32 or 30, and we knew about that low AMH, froze her eggs then her outcome at 38 would be way better. We had more eggs frozen that were younger, better quality, and hopefully chromosomally normal. So obviously, preserving fertility, why freeze eggs? We keep talking about how advancing age makes it difficult for women to get pregnant because of quality and quantity. What we can do about it is try and freeze eggs for women who are not ready to conceive earlier. The whole egg freezing lost its experimental status in 2012. So it's no longer experimental. So it's really important that we at least have the conversation. Not everybody will freeze eggs, but if the conversation is had, women have made an informed decision to freeze or not to freeze. At least they got given that option. Lots of people that I see later in age were not given that option. And obviously things are progressing now. Science is progressing. People are becoming more and more aware. So it's one of those things that we're talking about. It's great we are here, we're talking about it, which means we're spreading more knowledge. As you can see, as women get older, the egg that we retrieve in egg collection also reduces. So when younger women have egg freezing, the number of cycles that we need to actually freeze the eggs also reduces. So we need less number of cycles and get more eggs out of those age. Just for example, a 37-year-old has a 50% chance of conceiving with 10 eggs. So the younger the person is, the higher the number of percentage of success or live birth with lower number of eggs. So this is less than a 35-year-old who has 10 eggs frozen, and she has a 70% chance to conceive. So that's pretty self-explanatory. Again, success rates. How do we know that those eggs that are frozen are actually going to be any good? So the way I look at it and the way I explain to my patients is think about a woman having IVF at that age. So if I got a 32-year-old freezing her eggs, I explained to her that it would be the same success rates as it would be if you were having IVF now. So I got a 39-year-old who was just not in the position to have a baby and she wanted to freeze her eggs. Pretty much it would be, the success rate would be of that person having IVF at that age, which is not that much at 39. But again, that's what she wanted. So if someone freezes her eggs at 30, at 32, that would be her success rates, which is pretty good. So we typically aim for 10 to 15 eggs, more if you're older. It depends on the age, of course. Like I said, AMH, body weight, and we aim for at 10 to 15 to get the desired number of live birth, like one or two. It also depends on patient specific factors. Not everybody will get the same number of eggs per cycle. About 85 to 90% of the eggs will survive the thaw process. And then 50% of them will fertilize with the sperm, actually more than that if they are younger eggs. And then 40% of the fertilized eggs will develop into mature embryos. Now, if they are older women, not all those embryos will be normal. And if we are in the position to test them, we could find a normal embryo and then transfer back. It's very important to explain to the patient that many women will not use those eggs. And that's actually the outcome we want. We don't necessarily want everyone to be coming back to use their eggs because we hope that, especially if they are young single women freezing their eggs, that they will actually conceive naturally in the future and won't use their eggs. But this is what we call the backup plan. I also often use the word called eggsurance. But it's the only thing that they can do to preserve their fertility or to be assured that there's something there in case they need it. They might need more than one cycle to get enough eggs, especially if their AMH is low. We can freeze those eggs for at least 10 years and sometimes with extension. The funny thing is that we can use up to age 53 to have a transfer back, and some women actually do use it for that long. And they can always give an advanced health directive as to how to manage those eggs if something happened to them, if their death happens to that person, whether they want to donate it, what they want to do with those eggs. Outcomes such as fertilization, embryo development, pregnancy rate is, as I said, nearly as good as fresh eggs of that age when those eggs were frozen. And then we have to think about whether we want to freeze eggs versus embryos. We don't encourage people to freeze embryos unless with specific counseling, and in certain circumstances it may be possible, but usually we recommend freezing eggs, particularly if it is just the one person involved. But in certain situations, embryos may be frozen, but that's a discussion to have had. Obviously, embryos, when the embryos are frozen, it is life. It has happened. The fertilization has happened. Embryos are created, and they can be frozen for later. Usually, for example, in cancer situation, in other situations when they're already partnered and they want to have a baby later, it's more assuring to freeze embryos than it is eggs, because eggs still need to thaw, fertilize, become an embryo. But currently, the preference is oocytes. And in this situation, it is not tied to a sperm. So this is a discussion to have had with the couple. Okay, so this is what I had to say. And now I'm ready for the questions. I hope I've got a few of them there. So I've got some really good questions. There's one question that says, do you recommend doing an AMH while patients are on contraception, or it's best to have them stop for a period of time first? So it again depends on what contraception the person is. Progesterone-based contraception, especially like a Mirena or a Implanon, does not need to be stopped. There is some suggestion that even these drop the AMH by a small percentage. So it's kind of not significant enough, but definitely the oral contraceptive pill, especially the combined pill, should be stopped minimum of 4 weeks to allow for the correct AMH. Otherwise, it actually gives a very false impression. It's almost halved to what it can be. So definitely stop the oral contraceptive pills for a month, for 4 weeks. I usually ask my patients to stop it, have a period for a whole month, and then test afterwards to have the accurate assessment of the AMH. And then at what AMH, the next question I have is at what AMH level is concerning and when we should refer in, what percentile? That's a really good question. And I think it's really, there's no like a right or wrong answer, but it depends on what AMH for what age. So if you have, and what situation the person is in. So if you have a person who is 40 years old and then an AMH of 6, for example, that is not unexpected for that person. But if she is trying to conceive and has an AMH of 6, that is low. And she should be referred in for IVF, or because she doesn't have much time. On top of that, she has a low AMH. But if you have a 32-year-old who has an AMH of 6, that is really low for that person. So she should be referred in. A 32-year-old with an AMH of 12, even though on the graph it is low, it's not concerning. So it's really difficult to say on percentile as to what it should be referred in. And it depends on what the person is trying, what is happening in that person's life. For example, I had a 36-year-old today with an AMH of 9. She's been naturally pregnant before, has not started to try to conceive. So I said to her, you need to try naturally for 6 months before we need to think about IVF, because it's not low enough. And she's been pregnant. So you've got to put the clinical context with the low AMH at the background of it. I hope that answers the question. Does a low AMH indicate low egg quality? Usually not. The AMH is just an assessment of number. The egg quality is pretty much age related. Low AMH is not usually a reflection of egg quality, no. Yeah, so that's about egg quality, AMH. I'm thinking like I can go through with a few clinical scenarios that I have whilst I'm waiting for a few more questions to be typed in. Please feel free to keep jamming in your questions, because this is your opportunity. I have a few patients with premature ovarian insufficiency lately. I've seen in the last month, one was 18, one is 31, and then AMH is all under like less than 1.2. So that is very, very low. And I wish I had seen them earlier with no history. And a few young women with an AMH of 2 and under who have just been pregnant with IVF. So it's young women with low AMH are easier to treat than older women with low AMH because of their quality. Is good when they're young. And when they're older women with low AMH, it makes it really, really difficult. There's a question about what about sperm? Usually we don't do AMH in the men. And obviously, there's different ways of assessing sperm, like DNA fragmentation and assessing sperm. I'm sorry, I'm just a little bit confused. A little bit confused about the question. Is the question about asking how do we assess sperm separately? Please, could you expand your question again, and I will answer. Whilst we are doing that, there's another question. Do you see low AMH levels in endometriosis? And if so, do you ever see it go up after lap excision of endometriosis? It's a really good question. We often see low AMH when ovaries are involved in endometriosis. And that is usually because of endometrioma. And unfortunately, it doesn't go up after surgery. In fact, there's lots of evidence now that if you have small endometriomas under 3 centimeter, we shouldn't be excising it because of further drop in the AMH. So maybe consider leaving those endometriomas alone and then proceed with IVF. So with the endometriosis and IVF, there's a discussion. So overall, the success rates with endometriosis and fertility is a bit lower. But should you do surgery or should you proceed with IVF is a very nuanced discussion. With minimum to mild endometriosis, removing it, doing surgery improves natural fertility. But when there is advanced endometriosis and endometrioma, there's a lot of evidence now coming up that don't worry about surgery, go straight to IVF. Now, again, that's not something that is just a blanket rule and one fits all, because when we do IVF and it doesn't work, lots of our specialists will then do surgery anyway. But let's just say let's say for argument that the success rates for a 33-year-old, 34-year-old with or without endometriosis, let's say for tubal reason, was 40%. And now with endometriosis, it is 35%. Whether you did surgery or whether you didn't do surgery, for someone with advanced endometriosis, it was 35%. So the preference is go straight to IVF in that advanced endometriosis age group. And the AMH will not have changed that. There's a question of how much does a 10-year of egg storage cost a patient? I think Monash team will be able to answer that question for you, and I'll direct that question to them. I think it will depend on whether it's medical, it's social, whether it's cancer or non-cancerous, and all of those. So I'll let them answer that question for you. The next one is it worth repeating the AMH? If so, what's the period required to remit, especially in a young woman aged 25 to 30? It's a really good question. I would repeat definitely. If you've acted on it, then that's okay. But if you've not acted on it, like say you've picked up someone at 25 to 30, and then you found that she's got a low-ish AMH, and you're like, okay, I'm going to sit on that and repeat it. I think in 2 years is a reasonable time. Look, there's no research or anything for it, but I would say maybe in 2 years it would be reasonable to repeat it. Lots of women will want you to repeat it in a year. It's $90, doesn't hurt to repeat it. And then maybe with that information, you would 25. I think the egg quality is at its peak, and sometimes it's a bit too early to do anything for it. Let's not talk about the rare cases, but in general, about say at 30, and if it's low, then I'll definitely be repeating it at 32. So I've got another question here, and I'll have to wrap up in the next 3 minutes, but I'm going to answer a few more. If a patient freezes their eggs at 36 and then meets a partner and wants to have children when they're 40, is it better for them to try naturally or to use their frozen eggs? It's a really, really good question, something we see often in our clinical practice a lot of. I would say check what the AMH is at the time, and what the family size is that they want to have. If they're wanting to have a large family with 3-4 kids, and if the AMH is reasonable, I would first go with their own eggs. Oh, when you said try naturally, I would assume that most people would try naturally for 6 months before they come see us, even in that age group. The other option is whether we do egg collection, we're at 40. That's the other thing. So I think trying naturally for 6 months is not unreasonable. But more importantly, I would do a fresh IVF cycle or use their frozen eggs at 36. That's the other thing. I would try a fresh IVF cycle and see if I can get eggs and tested embryos. And then maybe if that also didn't work, then I would go back to using their 36-year-old, because those eggs can be used for the second or third pregnancy as well. So it depends on what the couple wants, whether they want one child, they want more than one child, how many eggs were frozen at 36. So that's a discussion to have had at the time. But yeah, say if they had 15 eggs frozen, it's pretty comfortable. It wouldn't hurt to try one more time and see if they got nothing, definitely use that. But if they've got 6 eggs frozen, I definitely want to try now when they're 40, not 45, and we can hopefully get some more. Also depends on the AMH. Yeah, I hope that's helped answer some of the questions. And we'll see you next time. Thank you very much.